Okay, so recording's been set. So just to repeat myself, thank you for those joining this event this afternoon. My name's David Crosby from Partners in Care. I'm the Chief Officer, and we've got colleagues from Shropshire Community Health Trust joining us today to give us a presentation on virtual wards, which has been running for about a year. Give them a chance to give a presentation, show a short video, explain how the process works, what you can expect in terms of support for clients that you're supporting who are under the virtual ward process, and then an opportunity for you to ask any questions to the team at the end, if that's okay. So I'm going to pass over to Steph, who I think is going to lead, but she's got colleagues joining her from various locations around Shropshire. Steph.
Thank you, David. Apologies. I'm not alone in this room. I don't know if anyone can see behind the blur, but I will not let it put me off as best as possible. So, hi, thanks for letting me come along today. I'm Steph Wedmore. I'm the clinical service manager who works for Shropshire Community Health Trust. And I've been lucky enough to be working with the virtual ward team in some of the really early planning phases. So sort of seeing it grow and go from strength to strength. So we've had a couple of presentations in the last few weeks, which has been nice to get a chance to do some reflection. So from some of those earlier conversations versus where we are now, and it really is quite it's something that I think everyone who's working on the service is quite passionate about, and we understand that we need to take it that next level now and make sure it's really embedded in everyday practice for patients who are living in 24-hour care facilities, or those residents who have been supported by regular domiciliary care agencies, hence being here today. So I'm going to introduce my colleagues in the room there over at Halesfield as well. So we've got Julie Roper, who's our clinical lead for the virtual ward and rapid response service. Some of you might know Julie from her years and years of experience in the Telford rapid response and the care home MDT services, and so she's gone from sort of strength to strength at developing alternative to admission teams and pathways. And sat next to Julie there, we've got Laura Bradshaw, who's Business Support Officer. I've asked her to come along today so we can get some timely dissemination of any information if people want further comms or telephone numbers or contact details or any such material. Laura's the girl, she knows where it's all kept. And then sat opposite them, beautiful pair, we've got another beautiful human, Mark Goodfellow, who's a digital clinical lead. So Mark's also got a vast experience of working in an urgent community response service, being that first line of defence for admission avoidance as a nurse with a nursing background, but then has gone into a digital skill set that I think's probably always been there. And I guess I haven't really done you very much justice there, Mark. So if you want to come in and introduce yourselves any more, so pop your hand up. Otherwise, I'm going to move us on.
Yeah, I mean, the main one for me is that I'm a registered nurse and I'm doing this to support nursing care, not to get away from nursing. Both myself and Julie have got uniforms and bags packed at the ready. So if we do need to go out and see somebody at short notice, we do go out and see them. You might even get to speak to us on the triage line at times as well, which we do cover. So we're certainly not doing this to get away from nursing practice or seeing patients, quite the opposite.
So with the introductions there, I'm going to move us on. We've got a short video. Some of you might have seen it already. We were really lucky enough to work with a local filming crew who sort of specialise in promotional videos. So they spent some time with us and a few of our patients. So I think it's about 4 to 5 minutes long. So I'm just going to switch that over now. Please let me know if you can't hear it. If you can't, I don't know what I'm going to do about that, because that's outside of my scope of practice. So fingers crossed. Okay. So just a short video on some of the bits that the team are managing day to day, and obviously the point of us kind of presenting in this forum today is that we wish to extend that out wider across Shropshire, Telford and Wrekin. So I've added a bit of a slide here about what is a virtual ward. So this is sort of one of the NHS England's cornerstones for a virtual ward. In essence, what we, as the video alludes to, it was introduced to relieve pressure to the acute hospitals where patients require medical management, but where it is safe and beneficial to those patients to do so within their own home. Virtual wards provide hospital level care to people within their own environment. This includes providing urgent access to hospital level diagnostics, delivering interventions and providing care through daily multidisciplinary input, which may be enabled by digital technology, hence the name virtual ward. So the length of stay target is approximately for a 14-day period. However, locally we have kept people on longer if it's been clinically indicated. So, you know, it really truly is an alternative to admission service. We have a consultant, a secondary care consultant who works with us full time. We have a GP with special interest who knows particularly the south of the county. And we've got a lead ACP with an excellent respiratory background. So between the three senior clinical decision makers, there is a point of escalation 7 days a week for any patient who is not improving as anticipated or who requires additional sort of medical support. So it really is secondary level care, but in the community. So I'm going to take us on. This is a slide. It's not an inclusive slide necessarily. It's just a bit of an idea as to, you know, those sorts of patients who might be suitable for a virtual ward. So the first one, and this slide was developed by our consultant, is any care home resident. So Dr. Damon has got specialities with frailty and general medicine, acute medicine. So he's particularly geared for this line of work. And his big belief is that any care home resident should have the should have the option to be managed within their own home. But you know, those patients who are within their last 100 days of life, this should be kind of an option for them. Any patients who are housebound, patients who have had attendances to EDs within the last 6 months, all of those sorts of people should be considered for virtual ward in the first instance where it's safe to do so. And then we can sort of support with the rest of them really. So patients who may need IV antibiotics in the community, that's the type of work that our team will be able to facilitate. So we all have that difficult moment, don't we, where we go and see a patient and you can see they're quite poorly. However, they've got advanced care plan that states they're not for admission. If a suitable alternative can be found. So here's our plea for us to be that suitable alternative. I've got some details about how to make a referral later on in the slide deck. So I'll let that list go out, David. And hopefully that will sort of support some more local residents to be managed in the community there. Mark, did you want to come in?
Yeah, I think it's worth emphasising that what we do is we seek to include, we don't seek to exclude. So a lot of services, you'll find they've got some really, really quite strict criteria in what they will and won't accept onto a service, where our ethos has always been that if we've got some reason to have them on our virtual ward, we will get them onto our virtual ward. So this is more of a kind of indication of what we will take, as opposed to an absolute strict criteria of what we will take on there. So it's always best to ask and have that discussion rather than just assuming that we won't take that person onto the virtual ward.
I've included a little slide about digital monitoring as well. And Mark, I'm gonna lean on you maybe to just a brief explanation as to what it is that some of the care providers might come across if they've been asked to support with some digital monitoring. You're on mute if you're talking.
Okay. Yeah, we've got a remote monitoring solution in place at the moment, but we're looking to get that changed and move over to a different system. Essentially, it is taking a resident's observations or client's observations using some form of technology. That might be a tablet, that might be a chat box on a web page that you put them into, and then they will come back to us along with some questions we'll ask about how the patient is just doing in general, and then advise and support from that going forward. So there's nothing onerous or kind of difficult about it to do, and if there's any kind of concerns, we will offer some training and support on being able to get that done. But I believe most residential settings have got the ability to record patient observations. For domiciliary care, that will be different, and we won't kind of mandate or force that you have to do it. If you've got staff that are willing to do it and you're happy as the providers and managers for them to do it, we will support that. Equally, if you've got some concerns and you're not happy with it, again, we will support you in that that decision.
So this was when I came to create this slide deck, I kind of thought, where do we go now? And I think actually what was important was also to talk about the rapid response element of the service. So the second half of the slide deck, I'm going to hand over to Julie, and we'll maybe co-present. I'd say she's lived and breathed rapid response for the last 2 decades, I think, so she's probably going to be the best person to talk to it. So I've just got a little introduction here, Ju.
Yeah, so as Steph said, I've lived and breathed rapid response for a very long time. You might hear the rapid response alluded to now as a urgent community response, one and the same thing in essence. Basically, in essence, the urgent response is to prevent avoidable hospital admissions wherever possible and to enable people to live longer in their own home. With the aim of rapid response, we aim to prevent or do an assessment, within 2 hours. So we aim to be with the patient within a 2-hour time frame to prevent any further deterioration and obviously enable optimal treatment and monitoring in a really short period of time frame. So the difference between rapid response and virtual ward is that we support people on rapid response for up to 72 hours. Obviously, it's a really short, snappy support people in crisis to prevent that admission to hospital. And obviously, that's the point where we've done everything we can to maintain that person at home and support them in crisis. And that's where we might want to move that person onto virtual ward afterwards. So in essence, urgent community response is a really short, snappy, monitor and manage someone in crisis. And then what do we do next, basically? This is the beauty of virtual ward, because we did have that time limitation in that rapid response. We recognised where people were still at risk, and obviously the cohort of patients that we do look after aren't always optimised after that 72-hour period. So we recognise that, and obviously wanted to obviously have that ability to support patients for a longer period of time. And this is where, in essence, we can we seek the support for virtual ward. Obviously, it's keen to note that UCR is not a replacement for primary care, so we're not a supplement for primary care. Obviously, we work alongside primary care. So in essence, for those people on UCR, we work alongside the GP to support that patient at home. And that's the difference between, again, rapid response and virtual ward. We still work with the GP for that UCR component of the service, whereas virtual ward, those patients are onboarded with our own medical team, and that's the difference between the two.
Yeah.
Thanks, Steph. Do you want to add anything in there?
No, perfect. Thank you.
So these are, again, not an exhaustive list, but these are the types of conditions, presentations that we will see people on UCR with. So we do a lot of urgent response to falls now. As you can imagine, there is a huge response or need for falls across the county. We are working with our ICB commissioners at the moment, and we currently are supported by non-emergency transport called EMED to support with that urgent response to falls. So where patients are falling and they're on the floor, we work together to try and support that patient to remain at home on our falls pathway. That service is available during the day with urgent community response and through EMED through the evening. So should a call go through to West Midlands ambulance for a patient who's fallen, they quite often will divert that call to us now. We have lifting equipment to support us. We have 2 pieces of lifting equipment. We have a Manga Elk and a Razor lift, and we have those in all parts of the county across Shropshire, Telford and Wrekin. Decompensation of frailty. So we look, see, as you can imagine, a lot of older adults who are extremely frail, with obviously multiple other minor stresses that are going on in their life as well, such as UTI, chest infections. Those are the cohort of patients we'd expect to see every day on rapid response. We will see urgent catheter problems, so acute retention of urine, particularly so. So we don't replace the need for district nurse, but they should be called in the first instance. But obviously, if there's a risk that patient may be taken into hospital because of that acute need, then obviously we will go out as an urgent response within that 2-hour time frame. We'll also support patients with diabetes. So again, urgent support for diabetes, where that patient's having an unstable, uncontrolled episodes. We'll go out and monitor those that for that period of time to manage that patient in a home and reduce the risk of admission. We do see multiple patients with confusion and delirium. Obviously, that can be secondary to obviously an acute cause. And also we do see patients in who are palliative in an end of life crisis. Obviously, what we'd hope that patients don't end up in crisis in the palliative stages of their life. We'd hope that would be managed and preempted, but obviously we do see people that are in crisis in the palliative stages of their life at the end of life, where everything isn't in place, unfortunately. So those are the patients that we would respond to in a 2-hour crisis to support them at home and prevent them being admitted to hospital. And this is again our criteria, so inclusion and exclusion criteria. Again, we kind of encourage any conversations really with where possible to our triage team. But in essence, anyone that is included is any patient over 18 with a Shropshire, Telford and Wrekin GP. We do actually support patients over borders as well, so we really don't want to kind of penalise anybody really from being admitted to the service, and we are happy to have conversations. So for those border patients that that kind of sit on the peripheries of Shropshire, Telford and Wrekin, any patient that is in crisis, by definition of the fact that they need that 2-hour response to try and keep them at home, and support people living with dementia in their own homes. And we like to work together with the mental health services to support that person where possible. Exclusion, although we've got their acutely unwell and injured patient, the acutely unwell, we will work with our virtual ward team to obviously see where possible to keep that person at home. If we feel that we need that step up to the acute virtual ward team, we will have that conversation jointly with the team. A patient that's experiencing a mental health crisis is one of our difficulties, really, because we don't have a mental health component within the team, but we will use our specialist services around us to support us to signpost that patient to the right place. And then where patients need complex diagnostics, one of our probably limitations is access to diagnostics, which obviously we're working alongside the virtual ward team to support those diagnostics at home, but we don't have access to the likes of imaging like MRI scanning, CT scanning, that kind of limitations that we don't have at the moment, so which we would like for the future. And this is our referral number. So what we have done over the last 12 months is created one referral line into virtual ward and rapid response. What we want to reduce really is the risk of patients or referrers, not knowing which service to refer to. So at the end of this phone line, you'll see our call handlers and our clinical triagers. They will signpost the page or a referral or patient to the right place. So it kind of negates really anybody having to think about, what they need. They just need to ring and refer to us and we'll do the rest in essence. So we'll signpost to the right service, whether it's rapid response or virtual ward.
There we are. Whistle stop tour of the service, which has taken a good few years to build. So hopefully that's shed some clarity on what we do and how you can utilise the service. But if there are any outstanding questions, we've got half an hour now, which I think was about right, David.
Yeah, perfect. Thanks, Steph, Julie, Mark. Open up to questions from those present. I've got a couple. I'll get in first, if that's okay. So the rapid response team line is open 8 till 8, 7 days a week. What happens outside those hours? And if somebody calls at like sort of 10 to 8, does the 2-hour call out window still apply, or does it close? Do you stop going out after 8?
So the teams work until 8:30. So if there is something that can be quite simple, and I say that, we've got this strap down, like it's never just a commode. But if it is something that maybe can be seen quickly and safety netted until the following morning, they will endeavour to get out and support. Outside of the hours, we would divert through to NHS 111 for any sort of further advice. So the teams would be diverted into Shropdock for out of hours support.
Okay.
So I think it's important to note as well that where rapid response, currently we have this 2-hour time frame limit. So we are expected to respond within 2 hours. If it is clinically the right thing to do to let a resident or let a patient kind of have an evening, and then we come first thing in the morning, we'll also clinically triage whether or not that's appropriate to do, whether that's safe and appropriate, and offer some safety net and advice. So there could be a scenario at 10 to 8 and one of your residents is looking quite poorly, but they're comfortable, they're in bed, you're confident that you could probably manage them through the evening and through the night, and actually you want some support first thing in the morning, then we can have that conversation at that time and then come and visit at a time where it is a little bit more socially acceptable for that patient if they're settled. Mark has said, we'll always endeavour to try and support where possible.
I think I'll let Julie say what I was going to say.
I was going to say, quite often at triage, we will take if the referrer can give us as much information as possible in terms of sort of an SBAR, situation and even observations, we can obviously help to sort of make that informed decision as well, whether that person is able to remain at home or not. So it just gives us more background, more information about the particularly at triage, really, whether that person does need to be seen now or whether that person can wait till tomorrow.
Yeah, so on the triage line, what we've got is we've got clinicians that work in the service who are band 6s and above. So when you actually phone there, either you're not just speaking to an admin person who's taking a referral and passing it on, you will get through to somebody who is a clinician who is familiar with the service, is familiar with the patient group, who can advise and support accordingly and come to an agreement about what it is that is going to be done. Sometimes it is just providing some assurance that actually that's fine, everything that's being done can be done. We'll pick up first thing in the morning and review from there. A lot of urgent community response is taking the heat out of the situation where it's a lot kind of uncertainty, people not quite knowing what to do. So we take that through and forward. Sometimes the discussion will be, well, actually, based on what you've said, that needs to be actually an ambulance response because there's a few things there that we're just not happy with and it wouldn't be appropriate to go through to the out of hours. So even if we don't, it's getting near kind of the end of the day and you think, oh, they won't be able to respond, it's still worth having that discussion because then we can agree what the next steps are and support you with that.
Okay, thank you very much. We've got lots of hands up, so I'll save my second question till the end. I think Dawn was first. Dawn?
So I'm done. We work in domiciliary care, and I can say the experience we've had working with the virtual world was excellent, but I just want a clarification on one issue. So if I'm phoning up for advice and everything else, it is brilliant. What I don't understand is your record keeping from when you're going from, because, and I 100% appreciate how busy you are. So people were phoning me back at 8:30, 9 o'clock at night. So I know it's not a 9 to, it's not 8 to 8. It goes well past that. But when people were phoning me, they were asking very similar sort of questions to the questions that the person I'd spoken to previously had asked. So I just wasn't sure how things were recorded to enable the team to have a better continuity of care, for want of I can't think of a different word for it, sorry. But it's just so that everyone is at the same place. And when you're phoning, when you're phoning to speak to a care provider, that you have all of that information there, and it didn't always seem to tie up. So different people were coming in every day, and it wasn't all being matched up. So it's not a question, but it is, how does that work? Because that's the only issue I had. Everything else was amazing.
So we've got a record system, electronic record system that all our clinicians can access. That is different to what the GPs use. So that is one of the limitations, Dawn, that we maybe were seeking for some support with. So if you've been involved in a service user for a long period of time and you've got a good, general rapport with their GP, then there could have been some information maybe where we needed to sort of close a gap a little bit, and that's perhaps why you were getting questioned about your service users presentation. I think the other thing to document is that with patients who are frail and older, when they become poorly, we all know this, they can change quite rapidly. So it's often that set of questions that will help build a clinical picture as well. Which is maybe why you felt like you were getting the same thing over and over again, and it's seeking any differences through the day. So I think that's going to be important in ensuring that we're kind of getting information from every relevant source. So yeah, I think if it's gotten to the point where you're having sort of the same questions fired off at you week in, week out, and actually you can't understand the reason for it, then we can have a little look into certain instances. If you feel like we've missed something, Dawn, but there could well have been a reason why the questions were repeated.
Yeah.
Oh, I understand that, but the question that was repeated the most was, what is the package of care? So how many calls a day they were having, how long those calls were lasting, that sort of thing. So that remains constant. It wasn't one that required clarification. So it wasn't necessarily a clinical question as far as, how mobile are they normally? How well do they mobilize? Where do they sleep? Where this, that? It was more around the package of care that I was being asked repeated questions on. So that bit I just didn't understand. And as I said, I had no issue answering the questions, and everyone was brilliant. It was just that sort of question, it didn't seem to be documented anywhere because they weren't quite sure, so they were clarifying.
I mean, that should have been documented in our electronic patient record. However, there could have been an omission there, and we don't work on the same system as social care. And Mark, I don't know if you've got any further.
Yeah, I mean, it's that my specialism, one of my specialisms is in digital records, digital technology. I can wax lyrical for many, many hours about various aspects to do with this. But from a clinician that is there with the workload and the pace that we've got, because don't forget within the service, we've got that 2-hour response time. It might be that within the set of notes that we are looking at, that information isn't there and present without going further back to the initial assessment to see what it is that is occurring with that one. So if you've got somebody from the care company there, then it is easier to ask that question there and then. Also, if the care package has been changed, as Steph said, we often do not have, well, we don't have access to social services systems. So it's a way also of checking that if there have been any changes within that that care package. At the same time, it's a tricky one to.
I think from the UCR perspective, obviously we do work closely with, you know, our domiciliary care providers. So things might have changed from originally at the first day of assessment compared to sort of 2 or 3 days down the line, where we might have increased someone's care package and then potentially reduced the care package down again, potentially depending on obviously the patient's needs. So that's the only thing I would probably think is where they're probably coming from, Dawn, is that because we have potentially increase that care package to get over that crisis and support that crisis, and potentially that might be still the case and that might still be going on, and that might then move on to sort of like an enablement package, or that might have been stepped down. So I guess it's probably because it might have varied, it might have fluctuated, it might have moved. Does that make sense in terms of what's required?
Yeah, and also if it's come as a referral through and we've taken that referral information, very often the referral information, when it comes to knowing what happens in community, there's a confusion or people aren't aware of what is actually being provided, or that's the information that they got from the relative that's now 3-4 months out of date potentially. So it's that, yeah, it is frustrating.
Yeah.
Can completely understand how it happens on that one. Yeah.
In terms of the clinical side of it, you're excellent. You answered questions for me above and beyond, and I do believe I spoke to you on one occasion and gave me a whole heap of information that you explained very well.
Yeah, it is one of those, the amount of information that we've got on the record and the organisation of that information within the confines of the system that we have got. Unfortunately, there will be times where questions might be asked multiple times on that one. Ideally, no, it wouldn't happen, but given the pace of the service and the system, I can kind of understand how it is on that one. So just bear with us on that.
Yeah, it would be great if at some point health and social care could all join up and be one, because it would solve so many problems.
I mean, we're lucky enough in Telford to obviously be in the same building, Dawn, which is great, and that was a move some years ago. So our social care providers are in the same room as our health providers. We don't have the same, unfortunately, we don't have the same mirroring across the county, and obviously that's just about sort of you know, that's just general difficulties as a system, really. So yeah, so it's much easier in Telford because obviously we can pop in to next door. So you might find it's probably a little bit easier in Telford's perspective because we can pop into the next room, but not necessarily for some of the rest of the county. So yeah, apologies from that perspective.
No, thank you. Thanks very much.
Thanks, Dawn. Thank you for raising that one and for the positive feedback. Thank you. Sue had a hand up.
Thanks. I've got 2 questions. I mean, first of all, to say it's a brilliant service, both aspects of it. So well done and congratulations, Julie. Haven't seen you for ages, but now I know why.
Thank you, Sue, as well.
2 questions. My first, 2 very different questions. My first one is, what's your virtual bed capacity and what geography does it cover? And do you have issues with capacity, and do you get bed blockers in your virtual beds?
So our virtual ward bed capacity is 167 beds across the whole of Shropshire, Telford and Wrekin. So to enable that, people are able to still receive the face-to-face care that you would anticipate someone who needs hospital level care to need. We've got 6 locality teams who work all across Shropshire, Telford and Wrekin. So we've got Church Stretton, We've got some clinicians who kind of work around the Ludlow area who are allocated to the Church Stretton team. We've got Bridgnorth, Telford, Shrewsbury, Oswestry and Whitchurch. And we tend to find that between the 6 sites, we can have like a bit of a blended approach. So each team will have like an allocation, a locality allocation. However, if there's a patient in Shifnal, for example, who Telford can't get to, then Bridgnorth will come down to. If there's a patient in, I don't know, Wem, for example, sometimes we'll even send someone from Shrewsbury over if the Whitchurch team can't get there. So we do have capacity issues. As with any health and social care provider, we're experiencing the same difficulties with recruitment, with retention, with sickness. We've had to utilise some agency workers. We've had to utilise bank workers. We don't love doing it because obviously you like to have the staff who know the patients, who know the service and who know how to escalate. And when you're running a really rapid paced clinical team, you don't often have time to do that really in-depth induction process for new locum workers. So the ones that we utilise again and again, so they know who we are and they know what to do. So we do sometimes find that we have capacity issues, which is when we'll then look at, we've got escalation cards that we'll implement. So we'll go for mutual aid from the next locality along. We'll ask for mutual aid from maybe some of the community therapy teams, for example, if they can do some of the review checks for rapid response patients, because that's it within their scope of practice. That will free up another clinician to go out and do an initial assessment then, for an example. We might utilise our district nursing service. If there's a patient on the virtual ward who requires a skin tear and a skin check, then we would ask our district nursing colleagues if they could support, and then that could free up a clinician. So we've got a number of escalation actions that we would look at implementing when capacity becomes an issue. And that's when myself, Julie and Mark will look at getting involved on triage as well. So we'll stop what we're doing, we'll take over triage, we'll take 2 of the clinicians back out and put them into the teams to be able to give a 2-hour response. So we really do try everything we can to make sure that patients are seen in a timely manner that's right for how they present. And the other thing might be, let's look at stretching that 2-hour response time. So nationally we've got a 2-hour target. However, the alternative is waiting 12 hours for an ambulance. So actually, if that patient is okay to wait for 3 hours, then let's not decline them. We'll take them. We'll make sure they're safety netted for that additional period of time, and we'll still respond, and we'll probably still get there quicker than the alternative. I think, so we do, and to answer the other part of your question, so we do often get some lag around discharges, and it might be that anxiety about kind of not having that resource any further. In which case we can do some coaching with the patient. You know, they can contact back if symptoms start to escalate again. We do offer self-referral back into the service for those patients who've already been known to us. It is a consultant-led decision to discharge, so Dr. Doman will have the final decision, and then patients go back into the care of primary care. So I guess we don't get bed blockers in your historical term, like there isn't physically anywhere for them to move to because they're already in the location that they're going to be discharged to anyway, aren't they? But there might be that disparity between what's secondary care and what's primary care. And that tends to be that medic to medic conversation that has to occur before discharge can happen then. The teams will also sort of support with a really robust discharge summary. So the GP is fully cited on what's happened while they've been under the care of the virtual ward physician. Any medication changes and so forth can be discussed. So just like they would get if they were coming out of an acute bed, they should have the same level of communication back into primary care.
And patients to say, sorry, Steph, let's just jump in to say. Obviously sometimes I think that's the sort of misconception about who do people go to during that time. So because obviously whilst they're onboarded to virtual ward. They're our medical team's responsibility. So everything should go through our medical team. So obviously, if you've got someone in the home, we you know, or wherever that patient may be, their own home, we just ask people obviously not to contact their patient's own GP during that time, because obviously then it kind of muddies the water between primary care and obviously our own medical team. So yeah, they sit within the responsibility of our medical team until we've discharged them. And like Steph said, the patient will get a discharge summary as well as the GP too. So they'll know at that point that they have been discharged from the service and back into the care of primary care and the care of the GP, really. So that's the only thing we sort of ask for patients to come to us for people to come to us for, you know, if actually they've got a medical need or a query.
Just going back to Sue's initial question around what area do we cover, then it is a patient who has got a GP that is in Shropshire, Telford and Wrekin for virtual ward. If they live in Shropshire but they haven't got a Shropshire, Telford and Wrekin GP, ideally it should be the health service within that area that should take them on. But we do know that in some areas they've done their virtual ward on the basis of residency. In that case, if they are resident within Shropshire but haven't got a Shropshire and Telford GP and their neighbouring virtual ward service won't see them, we will see them, because that's the right and appropriate thing to do for that patient. So if ever you're not sure, give us a call, and then again, going back to the inclusion, if we can include them, we will. We will try and include them.
Thank you for that. Can I indulge myself with the second question?
Yeah, certainly.
My second question, completely different. If in the community there's a care package that's being paid for by the local authority, the client comes under your care, and it's appropriate for that client to have an uplift, a temporary uplift in their support. So go from, you know, 2 calls a day to 4 calls a day because they're poorly. Who authorises and who pays the bill for the additional care that's been put in?
Do you want to go with that, Steph?
Yeah, that's always been a little bit of a challenge, but I think we're coming more to a system agreement now that local authorities will look under the UCR element. So any admission avoidance or, you know, crisis for a patient or for a resident where they need an increase in their package of care, it's always been a bit of a tricky subject, because I think some of the commissioning arrangements weren't very clear in the early days. So obviously our purpose is to keep more people at home. With that is going to come additional work and additional pressure for other people. We were asked to present at the HOSC, and this came up. So Telford have agreed that any temporary increase in package of care will be funded through the Better Care Fund, so through the same as the Enablement Fund, because the long-term view is that if you avoid that admission entirely and avoid any decompensation that will come as as part of that admission, then you're likely to reduce the long-term need for a greater package of care. Shropshire have been a little more difficult to engage with about that, but if you were in a crisis point, it is commissioned for admission avoidance that Shropshire will increase the care package to prevent admission. We have got health and healthcare support workers who can help supplement care packages as well in each locality. So they're funded through health, but they are anticipated that they will support with bits of personal care if that's the requirement for the patient to remain at home as well. So I think our first instance is to go through to start and see if we can increase the package of care through the admission avoidance channels. And then it's kind of a commissioning arrangement after that, which is still a challenge.
I mean, that's a shame that can't be sorted in Shropshire, because most clients don't want multiple care givers.
Yeah.
You know, multiple providers, multiple caregivers going in. It makes life terribly complicated for the provider, and it makes life complicated for everybody. So it's a shame that Shropshire Council can't just see sense and go, yeah, fine.
There's been a lot of, I think you'll experience it as well as us. There's been quite a lot of turnover in Shropshire Council. So as soon as you sort of get embedded with a couple of people, I think you then have to restart with new faces and new names and go back to the beginning. So we do kind of get to the point where we think it's going to get sorted, and then it kind of falls off a cliff and you start over again a little bit. Yeah, but yeah, it has been a challenge.
Thanks, Sue. And Steph, I have regular meetings with Shropshire Council, so I can pick that up with them, because what if that change in someone's condition requiring increased care becomes permanent, then obviously they should be doing a review under the Care Act to reassess the needs. We've got 5 minutes left. Pam's got her hand up. I was just going to mention, you answered one of my questions about the locality arrangements. I think my question was going to be how do you actually manage to meet the 2-hour window? But obviously, if you've got teams based all over the county, that explains that one. The other one I had before I asked Pam to come in is with the 2-hour window. The review, is that always face to face? It's because they've already been triaged on the phone.
So historically, we could stop the clock with a really robust telephone call and some safety netting advice.
Yeah. In
terms of informatics, that is not a thing anymore. So that clock only gets stopped once your face-to-face activity has been commenced. The NHS England are moving away from 2-hour response to any crisis response within sort of a 24-hour period. So some of the limitations are going to be lifted, because I think obviously people are aware that actually, like I said, the alternative is an ambulance, and that's often more than 2 hours anyway. So let's be sensible here and try and meet in the middle. So they are sort of coming to the table and allowing that to happen. So we just need to make sure we can gather as much information at the point of clinical triage to make sure that patient can be safety netted for that period of time. There is a poster that Mark's created that sort of supports with clinical decision making when you're trying to refer a patient over. So what I'll do, David, is get Laura to send that to you after, if you want to be able to disseminate that with the pack. And it just goes through, actually, is this patient for 999? Is it for rapid response or virtual ward? Is it for primary care? And kind of a brief SBAR handover to help support some of that decision making.
Yeah, that's great. Thank you. And Pam, do you want to come in with your question? You there, Pam? No. She's got her hand up. She's unmuted. So if just come in if you want, Pam. And then Jennifer's had to leave, but she put a question in about if there is any likelihood of being able to get mental health support capacity within the team, as that's something that she's experienced in her care homes, an issue where they've not been able to get support for clients.
I think it'll be coming. So we're currently in the process of a system-wide review of all alternatives to ED and alternatives to admission pathways. And one of the limitations that has been recognised is that access to mental health. So this has fallen out of SATH having their Getting It Right First Time review with NHS England. There's multiple work streams that have come out of it. Shropcom are leading on the what we call ATED and ATA, so alternative to ED and alternative to admission, and that's one of the themes that has been recognised. So I don't have any concrete answers at the moment about specialist support for mental health, but I think it's worth noting that it's been picked up as part of these nationally driven kind of work streams to ensure that there aren't barriers to providing an alternative for patients.
Okay, thanks, Steph. Thank you. I think Pam's put a question in the chat. Do you have any meetings with others you work with to provide this service to review progress? And then Keith's put, we have independent living service users. Can they have information to refer themselves to you, or does it always have to come from a caregiver? Also, do you work with GPs or refer to you instead of hospital admissions as an alternative?
Okay, so if I go to Pam's question first,
Yeah.
meetings with others you work with to provide the service to review if that's sort of patient progress day to day, then there's 2 meetings per day, which are our medical escalation calls. So that's 9 o'clock and 4 o'clock in the afternoon. The doctor is free; they're ready to take a call. So if there's been any progression through the night or any progression through the day, then there's a safe space to discuss that. And then each week, each locality will have a full caseload review led by the consultant or the GP. So each week patients will have all of their notes reviewed and their progress will be reviewed, and they look then at what's next for that care planning. So Pam, I'm assuming that that question was more related to patient progress, but if it's to do with service progress, then David, you'll be aware of some of the forums that we're regularly presenting on. Not so much anymore, actually. Now we've become a bit more business as usual, but we've got sort of a senior operational oversight meeting internally that happens every fortnight. This was part of the transformation programme for the system. So there were a lot of eyes and a lot of attention on virtual wards and rapid response in the early days. So a lot of assurances given and a lot of questions asked. Laura will be thinking back to those days that we were frequently scrambling to create information packs for presentations that fell out at last minute. I see Pam's typing, so I'm just going to flick over to Keith. So Keith's service users, the challenge with being able to refer yourself, I think, is actually, have you got an awareness? It's a really difficult one, isn't it? Because yes, we don't want to stop people being able to utilise a service that's created for them. But what we would encourage is actually, if they are feeling poorly in the first instance, that they would carry on contacting their GP. If you have a substandard, outcome from your GP and you're starting to feel poorly, then we will take referrals from patients. It usually is those ones who have been known to the service previously, but we've just got to make sure that we don't sort of accidentally pick up too much primary care work. And I guess we'll all get frustrated if we can't get in to see our own GP and pick up the phone and ring the next number for something that I don't want to misuse the service. So I think, yes, we can triage that referral. We can accept a call and triage that referral, but it may well be that it's decided at the point of triage that that patient should be signposted back to their GP, particularly if it's a long-term condition that needs sort of ongoing management, or it could be that we could signpost them to district nurses as well. So Julie, Mark, feel free to chip in if you think that that isn't quite the correct answer.
Yeah. No, that's fine. So the ones that patients that we do tend to get self-referring are generally patients who've got a longer-term condition, who know their condition well, what it's like, and are at the point where actually I need escalation to virtual ward because this is the level of input I need. The other one that we get is the crisis. Oh my God, I don't know what to do. I've been involved with you before. This is a number I've got. This is who I'm going to ring. And for those ones, we will absolutely do it. As Steph said, we don't want it to become a routine advertised patient can phone up and get referred onto the virtual ward. If they're not known to virtual ward already in some way, shape or form, or haven't been, then as Steph said, it should really be through the GP. And that's to protect the resource that we've got in the service, but also to make sure that we're not missing anything out and that GP practices are aware of the full demand on their services as well. Obviously, if we've got agencies' homes and they know that actually they know the resident, they know virtual ward, we don't mind them ringing as kind of that kind of proxy contact because they will have done some work already. They're familiar with our service. We can have that discussion to support.
And just going back to the second part of Keith's questions, yes, we're regularly working with GPs, so we're trying to showcase alternatives to admission, just as we are so doing here. I went up to Oswestry last week and had a bit of a similar conversation with those guys, and we're finding that we're just cycling the comms over and over again, really, before it gets, for it to become embedded. And I can see Pam has answered that her question was in relation to service progress. We had our Getting It Right First Time review last week with NHS England, and it was really positive actually. So our workforce model and our clinical model are kind of really barking up the right tree. There were a couple of recommendations to do with sort of information sharing and the digital element that came out that as a team we'll take back and review. But it was really good. I thought it was a really good review. It was really it was nice to hear the feedback, and I think it's just that chance for reflection to benchmark yourself against system partners as well. We do go to different virtual wards. We've been to different virtual wards. So the team over in Telford have spent time in Wolverhampton. I've engaged with gold benchmarkers in Hertfordshire. So we take learning backwards and forwards to each other.
It's good to see that obviously we are on the right track with that actually, because it's good to see how in the last 2 years we've come quite a significant way. We've had in comparison to other areas and other systems that have been in place for such a lot longer period of time. We've come quite a significant way in the last 18 months really. So and that's quite refreshing to see. We are at the moment just going back and reviewing some of our work streams and pathways and processes, because obviously we very quickly implemented the virtual ward in Shropshire, Telford and Wrekin and built the plane whilst flying it, so to speak. So we are going back again, and as an operational clinical team, like Steph just said, we're constantly reviewing those pathways, those processes. So that's a big piece of work at the moment for us to kind of take stock of where we're at and actually then be ready to move forward again and push forward. So
yeah, and in terms of the review, we've got the National Virtual Ward Sit Rep, which we complete, and then that obviously there is feedback from that. Within the UCR element, we've got a daily return that is going to NHS England as part of the Tier 1 work that's going on. So we've got scrutiny on that, and this week we've had some questions back about our performance around that. There's also some more other performance metrics that are being monitored, particularly around the UCR 2-hour responses that we're getting referred through to us. And again, we've had some questions around that. We've got other metrics as well that we're looking at. So part of the Getting It Right First Time review was looking at our length of stay, and we've got a length of stay that's just a little bit longer than what is going on nationally. We don't know if that's a good thing or if that's a bad thing, or it's just a case of that's what it is within Shropshire. So that's one area that we are looking at. Also as well, because of the work that we're doing around looking at records, particularly around where we've had increased length of stay, we're also doing review of cases, and then very often there are things that we will pick up from having reviewed notes, and then we will take that back through to teams. We've got a rolling process of education that has started, that has been done not because, oh, it's a topic and we'd like to do it, but we've actually looked at either what's going on within teams, things that staff have fed back, if we've had any patient feedback from it. So it is not a static service. If you were to step out of the team for 3 months and come back into it, you would be coming back into a different team. You wouldn't just be able to easily slot in, because things will change and things will update. And we'll also work with people across the system. So we've just had the OPAT service that has started, which is a governance process around antimicrobial use, to ensure that we've got good, appropriate antimicrobial stewardship in place. We've worked with that and kind of engaged with that process as well, which is in turn meant that our use of antimicrobials has also had that scrutiny involved with it. We're looking at getting electronic prescribing in place, which means that we don't have to send prescriptions about, but that will then also enable us to do easier reviews about our prescribing practices and our prescribing habits with that. We did the work with our single point of triage, and what we had from that is we actually increased capacity across UCR, because what we were able to do is, because people were getting through to us within 30 seconds and their referral was being logged within 30 seconds, that meant that we weren't actually losing referrals. We could then have a better idea about where we've got. So we are continually developing it and trying to push it forward through on that one, as well as scrutiny from places, not just around data, but actually about what we're doing clinically as well.
Thanks, Mark. Thank you. We've overrun slightly, but we did start late, so I'll let that go. And we've lost a few people. Obviously, they've got to head off to other meetings. But can I just say thanks to Steph, Mark, Julie, and Laura for all the information. Keith asked for a copy of the slides, which I'll make sure we get from Steph. I think I've got the draft one, but if you can send me the final one through and any of the other information that you've mentioned, and I'll also share a copy of the recording. So thanks again, and when you get the information through the contact details, if you've got any queries, please contact Steph and the team, and keep in touch with them and keep up to see what's going on. Thank you very much. Thank you. Thanks
you.
everybody.
Good for your time. Bye bye.
Bye. Bye.
Thank you. Bye bye.